Today we are presented with a 28-year-old African-American woman who comes to the clinic with complaints of shortness of breath and wheezing following a near asthma attack she had 2 days ago. At the time, she was at her cousin's house and was exposed to cats, which triggered her asthma symptoms. During the attack, she notes that her wheezes were a 6 out of 10 severity and her shortness of breath was an 8 out of 10 severity, and that it lasted about 5 minutes. At the time, she used her albuterol inhaler and her symptoms decreased, but they did not completely resolve. Since the incident, she notes she has had about 10 episodes of wheezing and has had shortness of breath approximately every 4 hours. Her last episode of shortness of breath was this morning before coming to the clinic. In regards to her symptoms over the past few days, she reports that they seem to be worsened by lying flat and during movement. They are accompanied by a non-productive cough. She complains that her current symptoms are starting to interfere with her daily activities of living. She awakens with nighttime shortness of breath twice per night. She is concerned that her albuterol inhaler seems to be less effective than it previously was. She has had no recent use of spirometry. She does not use a peak flow. She does not record attacks and does not have a home nebulizer or vaporizer. Currently, she states that her breathing is normal. In regards to her past medical history, the patient was diagnosed with asthma at the age of 2.5 years old. She's been hospitalized 5 times for asthma overall, last at age 16. She has never been intubated, and she does not have a current pulmonologist or allergist. Social history, she denies current use of tobacco, alcohol, and illicit drugs. She did smoke marijuana for about 5 or 6 years, but last used at 21 years old. She does not exercise. She is not aware of any environmental exposures or irritants at her job or home. On physical exam, in general, she is alert-oriented and sitting upright on the exam table. She maintains eye contact throughout the interview and exam. She is in no acute distress. Her chest expansion is symmetrical with respirations. She has normal fremitus, symmetric bilaterally. Chest is resonant to percussion with no dullness. She has bilateral expiratory wheezes in the posterior lower lobes. She has bilateral muffled words with notable expiratory wheezes in the posterior lower lobes. No crackles are present. In the office and spirometry, her FVC is 3.91 liters. Her FEV1 over FVC ratio is 80.56%, and her SpO2 is 97%. The plan for this patient for her asthma exacerbation, the patient should definitely be started on a daily dose of inhaled corticosteroids, which she should continue daily at this point, such as Flovin or Pulmicort. You should consider putting her on a short course of oral corticosteroids, not to exceed over 60 milligrams per day. And it's important to tell her to continue to use her short-acting bronchodilator for exacerbations, her albuterol. A lot of things to educate this patient on. You want to educate her on the importance of avoiding triggers that she's aware of. You want to educate her on the importance of spirometry usage for the future so she has something to compare to during her new attacks, and the importance of writing all of this information down so she's able to compare old attacks with new attacks. You need to educate her on the proper technique for using the spirometer, also the proper technique for using her inhaler to make sure she's getting all the medication that she can, and you want to utilize the teach-back method. You also want to educate her on the importance of having a pulmonologist who follows her and possibly going to see an allergist so that way she can be aware of what triggers her asthma so that way she can avoid those triggers even better. It's also important to have the patient follow up to see how she does when she starts this inhaled corticosteroid to see if possibly she needs to also be on a LAVA as well. See if she needs to step up after that or if she can step down if she's doing well. Lastly, you want to, of course, educate the patient on, the importance of going to the emergency room if she ever gets into her red zone on her plan. So making that action plan with the patient and educating her on how to utilize it and based off of her numbers when she should go to the emergency room.